Good evening, everybody, and thank you for joining us this evening for our online meeting about the ROI Reimbursement Scheme and the services available at Matter Private Network. My name is Adrienne O'Keefe, and I'm one of the team here at Matter Private, and I'm joined this evening by several of my colleagues. Orla Smith, many of you will have already been in contact with. Orla is the patient coordinator for the ROI Reimbursement Scheme at Matter Private, and she's your first point of contact with us. We're also delighted to be joined this evening by several of our consultant colleagues from across multiple specialties. So Mr. Ashley Poynton, one of our spinal surgeons, is with us. He'll be followed by Mr. Kieran O'Malley, consultant urologist, Mr. Mark Quinn, orthopedic surgeon, and Mr. Thomas Burke, ophthalmologist. So delighted to have all of the team here this evening and hope you will find the session very interesting and useful. The plan for this evening is to take you through a little bit about the Matter Private Network and what we do, where we are, and the types of services we can offer. And after I do a little bit of an introduction to that, I'll hand over to Orla Smith, who will take you through the basics of the scheme, how to apply, and the support she's available to provide to you. Once Orla and I have given you kind of an overview of Matter Private and the scheme, we'll introduce each of our consultants in turn, and they'll give you a brief introduction to the types of conditions they treat and what you can expect if you come to Matter Private to be treated with them. Once each of us are finished, then we will go back to Orla for some other questions and answers, and then we'll open up the session to you. So you can ask the questions that are on your mind, and you can send those through to us at any time during the meeting. There's a Q&A session or section at the end of the bottom of your screen, so you can use that to type your questions. And we'll do our best to get to all of the questions during the webinar this evening, but if there are any we haven't got time to answer or can't answer tonight, we'll take them offline and get back to you directly afterwards to answer them. So that's the plan for this evening. I would just ask all of our consultants maybe to turn off their cameras and mics now for the time being, and Orla and I will kick things off. So for those of you who are not familiar with Matter Private Network, we are Ireland's leading private hospital group. We've been established for over 35 years, and we are in 9 locations across Ireland and the UK. So we have 2 hospitals, one in Dublin, one in Cork. We have specialist cancer services in Limerick and a spine centre of excellence. We also have a cancer centre in Liverpool, and then multiple outreach clinics and day hospitals across the country. We're also a high-tech hospital, which means we have the expertise to support complex medical needs on site at our hospitals, and that includes cardiac, cancer, and orthopaedic conditions. We have an emergency department, an ICU, and cardiac care on site too. Over the years, we've developed a reputation for medical innovation, and this means you have access to the best possible treatment, the latest research and innovation with Matter Private. We have over 300 consultants across a wide range of specialties. Many of our consultants have worked and trained in the NHS, so they're familiar with the NHS system, and hopefully that provides you with some reassurance if you haven't travelled outside of the NHS for treatment previously. We're also a JCI accredited hospital. This means that we adhere to internationally recognised quality standards. We're audited regularly, and this is to ensure the highest possible standards of patient safety and quality of care when you're treated with us. One of the other key things that makes a difference for Matter Private is that we have a dedicated patient coordinator for the ROI Reimbursement Scheme patients. Orla is here to provide you with all the support and guidance you need throughout your experience with us. I mentioned earlier, we're located in Dublin and in Cork. We have our 2 hospitals in those cities. So in Dublin, we're a city centre location, which is very convenient for the train, for bus, and for the motorways. We're about 2 hours by car or by train from Belfast to Dublin, and parking is available nearby in public car parks right beside the hospital. Matter Private Cork is a modern hospital just outside the city centre. Again, we are available, easily accessible by car or by train. It's about 4 hours from Belfast. We also have fully private rooms in Matter Private in Cork, and there is on-site parking. For both hospitals, we have hotel accommodation available close by with preferential rates at several of those hotels. So if you need to travel and stay overnight before your appointment or after your appointment, again, you can easily avail of those services. That's a little bit about who we are and where we are. Orla, as I said, is our patient coordinator for the ROI Reimbursement Scheme, and she's your first point of contact when you have any queries about this, or if you're interested in finding out more about how you can be treated on the scheme and what you need to do to apply. So Orla is contactable Monday to Friday from 7:30 to 4:30. Her number is on screen there. You can also reach her by email, through the website, numerous ways you can reach Orla. So Orla, we might just people through a little bit of the background to the scheme and how they can get started. So in terms of eligibility for the ROI scheme, Orla, who is eligible for treatment on this scheme?
So any patient that's on a waiting list in the HSCNI is eligible. So this can be for a surgical procedure or a diagnostic test. The first thing you must do is make an application to the HSCNI for approval. I can help you with this, and this will give you an amount that you'll be able to claim back. So the first thing to do is to get in touch with me and I'll walk you through the process.
And in terms of how do people apply for reimbursement, what do they need to do?
It's quite a simple application form. So it's some of your own information, some supporting documentation. This would be from the hospital that you're on a waiting list in. So many patients may be on a waiting list in Musgrave Park for a joint replacement, so they can get a copy of the letter. And then the form is just their own information and some information about the matter private, which I actually provide forms that are pre-completed with all this information for the patient. So it's quite a simple process, as we're treating a lot of patients from Northern Ireland, and the questions are quite repetitive. They're easy enough to go through. And if you're not sure, I can help you and walk you through any of them questions.
Okay. And I think a lot of people will have questions about how long it takes to get approval to be on the scheme. So what is currently happening up there?
Currently, it's 6 to 9 weeks. I do think that there's been an influx in interest in the scheme, simply because a lot of patients are opting to go for a private service, and there is the option now to look into this and to claim some of the money back. So it usually was 6 weeks, but it's gone out to 6 to 9 weeks now. So just to be mindful of that timeline, and you have got until the 30th of June to get your application form in. This is the present cut-off date, so I would say get your forms in before the 30th of June. You will have a period of 9 months after that that you're valid to have the surgery done for. So just if you're thinking about it, try and get your forms in, sooner rather than later. Sometimes patients would say, oh, I'll leave it a little bit longer. I have till the 30th of June, but you do have to collate some documents. You do have to get some letters from the hospital, and they also look for a utility bill, proof of ID. So just to collate all that information, I would say give yourself some time and try and start putting that together.
Great. Okay. And as you said, Orla, the scheme as we know it currently is due to expire at the end of June. Now, we don't have any update from the scheme in Northern Ireland about whether that will be extended, but we're hoping it will be, as a number of patients are, concerned that they might miss out on the date. But as you said, get the application in before the 30th of June. And then once you're in the system, you have 9 months to go from there.
Exactly. Yeah. And we'll help you along the way to ensure, we're making sure everyone has what they need to get their applications in before then. So any queries, just get in touch with me. It's no problem.
Great. Thanks, Orla. Another question people often have is how long will they have to wait for treatment?
Okay, so it goes on specialty. So for orthopedics, such as joint replacement, I'm going to refer to that as that's what's most common that I see. It's usually within kind of 3 to 5 days, we can get the initial consultation in. And then for all other specialties, we're looking at within 2 weeks is kind of the timeline. Usually it's within a week, but we just say within 2 to be sure that we've given you enough time. But yeah, it's fairly quick for initial consultation. Once you've carried that out, if you need preoperative assessment, that will be arranged, and surgery is a short time after that. For example, joint replacement is 3 to 4 weeks. Other specialties, again, 4 to 6 weeks, depending on the surgery that's required.
Great. Okay. I think that covers probably the burning question most people have. What happens after someone has had their consultation? What happens next?
Okay, so the consultant secretary will get in touch with you. You more than likely will get your procedure date in the clinic on the day, so you'll be aware going home when you expect to come down. And then the admissions team will send you out a comprehensive list of what your admission plan is. So this would be fasting instructions, time of arrival, estimated length of stay, and then they also have a checklist with what to bring along with you into the hospital. There is a contact number on the end of this, so if you query anything with regards to the hospital admission, you can reach out directly to the admissions team. There's also myself you can come back to, or the consultant secretary, so you have numerous points of contact. If you've left anything out, it's absolutely fine, just let us know.
Great, okay. And then after the procedure, what happens?
So after the procedure, you will come back for your 6-week follow-up, where the consultant will see how you've got on. With patients who are orthopedics, they will go on and have some physio locally. And then sometimes with patients that are urology patients, they may need to come back for a stent removal if that has been put in the initial procedure. We do a 28-day post-op safety net for our patients, which covers you should you need readmission, second surgery, return to theatre. So there's a lot of comfort in that, in knowing it's quite a comprehensive package that we're covering our patients for. It's also covering you should you need to have ICU admission or access to the high-tech services that we provide in the Matter Private. And again, there's no additional charge for that. So the standard is 6 weeks, but if you need to come back before then, give me a call, reach out to the secretary and we'll look after you.
And I think that safety net you mentioned, Dora, is really reassuring for people. So if they do need to be readmitted for any reason related to their surgery or treatment with us during that 28 post-op day period, there's no additional cost. And that's
and you're going back
really
to the
reassuring
surgeon
for people.
Yeah, and you're going back to the surgeon who treated you as well. So a lot of patients do say to me, oh, if I'm well and I try to get back into my local hospital, no, you can come back to your surgeon. They've done the case, they will look after you and take care of you. So yeah, that's fine.
Yeah. Okay, this is kind of a typical patient journey, or you might just talk people through it. So if they're having a joint replacement, whether that's a hip or a knee, this is the type of experience they might have.
Yes.
Will you walk people through that?
Yes, so this is just a sample I put together for a joint replacement on what to expect and coming through to the Matter Private. So you'll have your initial consultation with the surgeon and we'll do an x-ray on the day as well. So usually say a hip or a knee, we'll do a pelvic x-ray or we'll do the knee, bring you into the clinic. The surgeon will have the images up on the screen. We'll go through the diagnosis with you, usually osteoarthritis or whatever the reason is. And then he will book you in for your preoperative assessment tests with your surgery date. So the hospital will be in touch with you about that. We also have musculoskeletal nursing on site too, and specialist nursing who will contact you, go through some information. The physiotherapy team also reach out to our patients to let them know what to expect while being in. We do offer a joint school too. What this is where you can meet your surgeon, physiotherapy team, the nursing team, all before your surgery. So some patients like to attend that and they find it the more you're kind of prepared for the surgery, even mentally knowing what to expect, that it's quite nice to go in and know where you're going. Then you'll come in for your surgery. Estimated length of stay is about 4 nights for a joint replacement. And then 2 weeks after surgery, the patient will be referred back locally. This is also, they can come to the Matter Private if they need to. A lot of them, they're just referred to their community nurse to get the clips taken out. And then the nursing will be checking in with you post-operative. And then 6 weeks, you have your consultant review with a view to being discharged from the hospital. Usually then we have had some patients that are listed for, say, a bilateral joint. So sometimes they might decide, right, I'm going to have the other joint done. In this 6-week follow-up, this is where they will discuss how you're getting on, the stability on the knee, the different things that you might go through. And then with the view, if you need anything else done, they'll look after you as well.
Perfect. Okay. So that's just a sample of what people can expect, but obviously everyone's experience is individual to them and their care is individualized as well. So this might not map exactly what they will go through, but it's like gives you an idea. Orla, I think that's it for the moment. We can let you off the hook and invite Mr. Ashley Poynton to come on screen and tell us a little bit about what he does. Thanks, Orla.
Thank you.
Good evening.
Thanks, Mr. Poynton.
Thanks, Adrian. Good evening, everyone, and thank you for your interest in Matter Private. I'm a spine surgeon. I've been working in the Matter Private for nearly 20 years. I have a very good feel for what Matter Private Hospital is and the level of care that it can provide. And that's very important for all surgery and in particular spine surgery. And we pride ourselves in the level of care that the hospital can offer, particularly the high-tech nature of it, the backup. We've got round-the-clock anesthetic cover in the hospital. We've ICU, as was already said. We have access to MRI scan round the clock if needed. And we have availability of spine surgeons 24/7. And that is very, very important when you're providing a spine surgical service. So what I want to get across is just some basic points about spine surgery. What is it? and who does it. So spine surgery is a very wide spectrum of surgeries for a wide spectrum of conditions, but the most common ones that you'll have heard about are disc protrusions, narrowing of the spinal canal, which is called spinal stenosis, and there are other more complex cases like scoliosis, spinal deformity, and so on, and some specialist areas like spinal tumors. We can do all of that, and I work with a team of 2 other spine surgeons, and we are all fellowship trained, which is very important, which means that we've all done specialist training in spine surgery, which is key because we have a very good understanding of the different conditions of the spine and how they should be treated correctly, and also how to treat any eventualities stemming out of the first surgery if there is a complication, which there usually isn't, but if there is, we can cater for it. Spine surgeons are either orthopedic surgeons or neurosurgeons. We tend to do the same types of surgery other than very specialized areas. So there's no real difference nowadays between neurosurgeons and orthopedic surgeons in terms of what is delivered and the types of surgery they do. The other big question that everyone asks is spine surgery safe, and what are the risks with complications such as paralysis or nerve damage? And that is always on everyone's mind coming into spine surgery. And the answer to that is in the vast majority of cases, spine surgery is very safe, and most of the conditions can be treated very reliably and easily without any complications. And the chances of a major complication are actually very rare. But it is important to have all the backup should something happen, and also the expertise to deal with it. We operate as a team, so we have surgeons, we have specialist nurses, we have physiotherapists, and that's very important because it's not just about the surgery, it's about the care before it, during the surgery, and directly afterwards. And also, we have a big emphasis on early mobilization. So you are mobilized either the day of surgery, usually the day of surgery, but definitely the day after. And that gets things moving quickly and actually reduces complications and gets you back on your feet and gets you home much quicker. We also have a very good pain service, which is really important with spine surgery, that your post-operative pain is addressed. So in all, it's a team effort, and that is extremely important. It's also important when you go home that you have a contact, and we have a spine liaison nurse that you can phone. So if you have any issues, whatever they are, whether they're minor or major, there's somebody there to speak with you. And if necessary, we'll get the surgeon involved. The types of surgery, the simplest surgery would be a keyhole micro discectomy or decompression, where there's a small resection of bone and disc to relieve pressure on a nerve. And then there are bigger surgeries such as spinal fusions, where the spine is unstable or the disc is worn out, where you need to put in screws or rods. And in most cases, the small surgeries, you can go home either day after surgery or maybe the second day. And the spinal fusion surgeries, you go home probably day 4 or day 5. Although that's reducing now because we're using minimally invasive techniques such as minimally invasive fusions and robotic fusion surgery, which we've quite a large series in the Mater Private. So the post-operative stay has reduced significantly. We also do a lot of neck surgery, so that would involve taking out discs and in many cases putting in little blocks and plates in the neck. And that is actually very successful surgery. It can be done very safely, and most people can go home second day after surgery. Another question that's commonly asked is, well, how do you get home, and do you need to stay around for a few days after you're discharged from hospital? And the answer to that is generally no. We would treat people from all over the country. They'll travel 3 or 4 hours by train or by car, And in general, that's fine, and there's no problem going home. Once you get home, there is, as I said, there's contact available with the hospital if there's any problems. And if you need readmission, we tend to get you in as quickly as we can. That 28-day window is really important. If you're having either a recurrence of pain or a wound problem, we'll get you back to the hospital pretty quickly for assessment. And we do have links with some of the surgeons in Northern Ireland. I would personally know surgeons from the Royal Vic and Musgrave Park. So if there is an issue, we'll deal with it, because the cross-border scheme works both ways. So some of the surgeons up there would have treated some of my patients in the past. So we've good relationship. The last point I'll make, and this goes back to your workup for surgery, that you will come to us and have a proper consultation. Even though you may be listed for surgery, we will start from scratch. We'll go through the whole process. We'll examine you. We'll look at your diagnostic imaging. We'll make sure that the surgery that you are listed for is appropriate and necessary as well, that we'll validate that. Not saying that your surgeon is incorrect. It's sometimes things change, or there's other options, and your symptoms may have improved, because many spinal conditions do improve over time. So there is a revalidation process, which is very important. And we'll also discuss other options, including non-operative care with you. And then the process is, as mentioned, there's often a preoperative assessment, and we tend to be able to get you in fairly quickly within a couple of weeks for your surgery. And that's all I'm going to say. I suppose, just to recap, spine surgery in modern, well-equipped, well-run hospitals is safe, it's reproducible, we tend to get good results in the vast majority of people, and I think that's very reassuring, and I'm happy to say that. Okay.
Thank you very much, Mr. Poynton. I think you've answered so many of the questions people probably have already. So that's great, and very reassuring for anybody who is needing spine surgery. If anybody does have other questions for Mr. Poynton, by all means, do send them through to us. We'll get to them in the Q&A once everybody has finished their short introductions. So don't be afraid to send in other questions you might have for Mr. Poynton. I'll ask Mr. O'Malley to join us on screen now. Mr. Kieran O'Malley is a consultant urologist with us here in the Matter Private. So, Mr. O'Malley, over to you.
Thank you, Adrian, and good evening, ladies and gentlemen. And thank you so much for giving up of your time this evening to tune in. Many of the points I'd like to make, Ashley has already made them very eloquently. But specifically with respect to urology, I'm one of 6 anchor consultant urologists here at the Matter Private. I've been here, I think, 18 years. And as Ashley has nicely put it, we're very proud of the hospital and our association with the hospital, and we strive to continue to raise standards and outcomes and to continue to do better for our patients and for our staff. So we certainly won't fail in our efforts to do the very best for the patients. The 6 urologists that work with me, we cover the full breadth of benign and cancerous conditions of the urinary tract, be that kidneys disease, stone disease, prostate, bladder, urethral reconstruction in some cases. But we've established an excellent working relationship with the team in Northern Ireland over the last 4 or 5 years, initially starting with prostate cancer cases, but it has certainly developed to include kidney stone disease, benign conditions of the kidney, benign enlargement of the prostate, and so forth. So we have a strong working relationship already with the team, particularly in Belfast City Hospital, also in Craigavon and other centres around Northern Ireland. My own particular area of interest is prostate disease, and in particular, cancer of the prostate, and since 2010 we've been fortunate enough to have had an opportunity to develop a robotic surgical program, largely concentrating in prostate cancer, but we've branched out to start doing robotic treatment of kidney disorders, bladder disorders, and indeed other non-neurological conditions, and Ashley mentioned spine disease as well. But the forefront of the robotic surgical program here has been the care of prostate cancer patients by minimally invasive robotic surgical techniques. And thus far, we've probably taken care of about 200 patients from Belfast City Hospital who've availed of our services through different initiatives. And I think it's safe to say that it's been an excellent program and a very successful program, and it continues to be refined, and we're continuing to see excellent results. And certainly the feedback from Northern Ireland has been outstanding. That's where our relationship with the team in Northern Ireland started. But as I say, we are now looking after benign disease of the prostate, which would be patients who have overgrowth of the prostate, difficulty passing water because of obstruction to the flow. And many patients have been sitting on waiting lists in Northern Ireland with catheters in for a very, very long time. And so we've had an opportunity to become involved in their care and indeed to get them back on the right path. Not through any fault of the team looking after them in the north, but simply an access issue that has created such delays. Like Ashley said, every one of our interactions begins with a fresh consultation at which we will have all of the urological history and imaging and data, including the biopsy results and so forth, prior to agreeing and establishing a definitive management plan, be that for benign enlargement of the prostate or for cancer of the prostate. So it all begins with a full consultation and a full debrief of exactly what to expect, and a complete walkthrough of exactly what will happen whilst the patients are in the hospital with us, what they can anticipate in the aftercare, and then once they're discharged. So whilst myself or Nicholas Hegarty might be the robotic prostate cancer surgeon, there is very much a big team effort involved here with our nurse specialists in urology, physiotherapists in urology, the specialist nurses on the ward, our anesthetists who are used to looking after these cases. Everybody plays their part in the journey of that patient, and without exception, we've had terrific feedback, and we continue to hopefully deliver on our promises. So the two most common procedures that we would deal with in urology for the patients from Northern Ireland would be robotic removal of the prostate for cancer, and that usually involves being in hospital for 2 nights and going home with a catheter in the bladder for 7 to 10 days, which is removed then in Belfast City Hospital. We have a very strong working relationship with the nurse specialist and the physio in Belfast. And the other procedure we would do is for the overgrowth of the prostate, and that's a TURP, or transurethral resection of the prostate, which is a telescopic removal of the prostate. And that usually involves a 3-night hospital stay, sometimes 2, but usually 3, and the patient goes home catheter free. Many of these patients come in with catheters and they go home without catheters. So they're certainly a very happy patient cohort. But those would be the 2 most typical procedures that we would cover. But like I said at the very outset, we cover the full breadth of urological disease, both benign and malignant. And we have a specialist who I believe can deliver almost any of the different demands placed on them by urological disorders. I don't have anything more I need to say. I just want to really touch on some big points, and that is that those are the 2 major areas we cover. Thank you, Adrian.
That's great. Thank you very much, Mr. O'Malley. And again, you've answered so many questions people probably have, but if they do have more questions, by all means, they can send them through to the Q&A function there at the bottom of your screen, and we'll get to those in just a few minutes. But thanks for that, Mr. O'Malley. You can sit back now and relax for a while, and I'll invite Mr. Mark Quinn to join us on screen now. Hi, Mr. Quinn. Thanks for joining us this evening. Over to you.
Thanks, Adrian, and thanks everybody for allowing me to talk tonight. And I just wanted, I'm an orthopedic consultant and I specialize in hip and knee replacement. And I just wanted to run through quickly what you would expect if you came to see us down in the Mater Private. The typical patient I would see is often around 50 to 70 years of age. And most people have developed either pain or have realized that they're kind of slowing up as regards their hobbies or pastimes they like to do. And I guess the main goal of joint replacement is to relieve pain and restore function. And what we're really looking to do is to get people back to doing what they like to do. As regards, as both Kieran and Ashley have alluded to, the main first step really is a reevaluation of what's going on as regards your condition, what needs to be done or not done. The main patients I'd see would end up with a knee replacement or a hip replacement, but there are other options, both non-surgical or, for example, a partial knee replacement is often offered in certain situations. Or sometimes people have bilateral disease or arthritis in both joints, and they may need something done with both of them at the same time. As regards when you come down to the Mater Private, again, say there'll be the consultation, and then if decided that we would go ahead, we would go through the procedure again, any questions that you had, and we'd hopefully arrange that then in the next couple of weeks. As regards what to expect with first off with a hip replacement, we would expect maybe a 2 to 3 night stay. Often people are home really actually on day 2. With regards to when we decide somebody's ready to go home, our physiotherapists work with you straight away after the operation. And really, once you're walking comfortably with either a frame or most likely with crutches, it's important we get people back onto crutches, because that allows you to navigate steps. And really, you know when you're ready to go home, basically, because you'll have started doing some steps with the physiotherapist. And after that, then, as regards traveling home, as was said before, patients from all across the country come to Mater Private, and even a 3 or 4 hour car journey is definitely doable with regards to a day or 2 after a hip replacement. The great thing about the Mater Private, it has a long history of performing total hip and knee replacements, so the aftercare services are excellent with regards to the physiotherapists on the ward and pain management. With regards to what happens after that, with myself, often my hip replacements have a dissolvable stitch, so they just need a little wound check at 2 weeks, and then I would see them back down in the clinic at 6 weeks for their formal x-ray, and usually that's the last time they need to come down. And with regards to recovery times, I say to people they're in hospital for about 2 to 3 days, and maybe driving again around 4 to 5 weeks, and around 3 to 4 months before you feel like you almost don't even remember the operation at that stage. With regards to knee replacements, I always say to my patients, knee replacements are a bit harder work for the patient, and they do tend to be sore. So say pain control is especially important with knee replacements, and physiotherapy is even more stringent. I'd have a pretty specific protocol with regards to knee replacements and managing with ice and analgesia and the number of times you need to do your exercises per day. But the important thing with a knee replacement is to have adequate pain control so that you can do your physiotherapy and get the best out of your knee replacement by the time your assessment comes back around at 6 weeks. Again, with a knee replacement, you'd go home after about 2 to 3 days, and it's fine to head back up in the car on that day. Again, it's a function of both whether you're comfortable on stairs and how the bend in your knee is going before we decide you're fit to go as such. And then with the knee replacements, there does be a few clips and they can be taken out locally. And again, I would see you back at 6 weeks' time for a formal check X-ray. And often that is then hopefully your last visit. And with regards to other options, as I say, some people, especially in their late 40s, early 50s, maybe a candidate for a partial knee replacement, and that's often discussed at that stage too. And there is then another number of procedures if required. But I say that's majorly what I'd want to talk about, really, and I'll leave the rest really for Q&A if anybody has anything in particular.
That's great. Thank you very much, Mr. Quinn. Really appreciate that. You have loads of lovely X-rays to show people, but we'll skip through those and move on to Mr. Tomas Burke. And if you can join us on screen, Mr. Burke, we'll leave any questions then for Mr. Quinn to the Q&A. There's already some coming in, and I think we'll have a really interesting conversation then about what else to expect. But thanks for that. And Mr. Burke, it's now your turn. So over to you.
Great. Thank you very much, Adrian, for that lovely introduction, and to you all for joining us today. I am a consultant at the Mater in Dublin, and my areas of expertise will include cataract surgery as well as the assessment and treatment of retinal disease, with more of a flavour towards the degenerative and medical end of the retinal disease spectrum, as well as inflammatory eye disease. Just a little refresher on anatomy for the audience, as well as maybe for some of my panelists. Cataracts, of which I've been asked to speak about mainly today, hardening of the lens, which leads to a gradual blurring of vision over the course of a number of years. Usually it's not a sudden onset condition, and we can see it here. It affects the lens towards the front of the eye. Some of the other conditions we treat, and also why it's important to assess patients who are referred to us for cataract surgery. You know, we worry about conditions that affect the back of the eye as well, such as macular degeneration, which affects a similar age cohort and can also lead to blurring of vision. Prior to me taking up my post in the Mater in Dublin, I was actually a consultant in the NHS. I worked in Bristol for almost 3 years prior to coming back to Dublin, and have done extensive training in ophthalmology both here in Ireland as well as in Oxford, Bristol and in London in the UK. And I have extensive experience working within the NHS delivering kind of cataract surgical care as well as retinal and inflammatory eye disease care. And, you know, well used to kind of seeing patients within the NHS and understanding kind of the dynamics of how the NHS works and how important communication is between all those various moving strands. And I'm sure you're all aware, you know, in the NHS, just like here, patients can be listed and diagnosed with the condition and listed for surgery in one institution, and then perhaps due to pressures on the system and in terms of ensuring patients get timely delivery of their care, they may have their treatment done elsewhere in the NHS. And I had experience working both in an NHS trust as well as in the independent sector. But just to give you a brief little overview just on what you might expect if you're referred to us with for assessment of cataracts. Just a reminder that cataract, you know, is one of the most common, or cataract surgery is one of the most common surgical procedures that are performed not just here in Ireland and in the UK, but also worldwide. And as with my colleagues, you know, we would aim to collate kind of any available clinical information that we have available to us from your referral. And then it would be really important that we confirm the diagnosis again. And just as with my colleagues and the other conditions, it's if you've been on a waiting list for a while, even a number of months, sometimes your condition may progress or other conditions may have developed. And it's not so much that we're kind of questioning the diagnosis, but just confirming that there isn't anything additional that we need to consider and or treat to ensure that you have the best visual outcome. So we'll, you know, re-examine your vision, dilate your pupils with those lovely stinging eye drops. I know some of you will have had if you've been to the eye doctor before, and then have a look at the back of the eye and have a look at the lens and just confirm that the cataract is present and that's what's causing you blurring of vision. And if there's any other investigations that we need to do, and particularly in terms of assessing the glasses requirements of your eyes or the strength lens that we need to put into your eyes, we would aim that that would be done kind of on the day of the clinic visit, where we will then also give you all the information again about your cataract surgery and ensure that you've had the opportunity to ask all of the relevant questions and have all your questions answered, so you're satisfied to proceed. And before you leave, we'd aim to give you the date for surgery. And obviously, if there were any additional investigations that we felt that it was in your best interest to get done before proceeding with the cataract surgery, then we would aim to have a date and time for those for you before you leave the clinic room. And then the next slide, please, Adrienne. And then on a particular day you attend for cataract surgery, you know, it's typically a day case procedure. So, you know, you may come in for a morning or an afternoon session. You'll be met by our wonderful nursing colleagues who will check you in and make sure that you're, again, if you've had the opportunity to ask any questions, your pupils will be dilated prior to the surgery in the eye that is for surgery, and then you will be seen preoperatively by the surgeon, where your consent form will be rechecked and just making sure that you're happy, that you don't have any other questions, and if you do, that those are answered. And then, you know, the vast majority of cataract surgery is carried out under local anaesthetic. The surgery itself takes approximately 20 or 30 minutes. And it's basically the use of ultrasound, which essentially breaks up the cataract and hoovers that out. And then we pop in an acrylic lens, which is inserted into the little bag that holds the lens in place. And that's it. You know, once you've had your cataracts done once, you don't need to have them done again. And the shield is usually placed on the eye at the end of the operation, and then you're back to the ward and you can be discharged home with clear instructions on what to expect post-operatively and how to use your drops. It's usually drops 4 times a day for a month, and then with a follow-up plan sometime kind of a month or so later. So that's cataract surgery in a nutshell, and obviously if you've any questions of that, I'd be delighted to answer them for you. Thanks.
That's great, Mr. Burke. Thank you very much. And speaking as somebody who's had a family member treated in matter private for cataracts, I can tell you that's exactly what happens. And she got on great. So it's very reassuring, I think, for anybody who's concerned about that surgery. Thank you for that. I'll get Orla back on screen now. And once Orla and I've gone through a few more pieces of information, we'll invite the Q&A to open. We've lots of great questions coming in already. So I think we're going to have a very interesting conversation. But Orla, some of the questions that we most frequently come across are about the costs and what's involved in terms of costs and how do people pay for treatment. So you might just cover that briefly.
Yes, of course. So each surgery, we will do up a bespoke surgical package. All surgical packages include your pre-op consultation, inpatient stay, and post-op consultation. So I'll take a joint replacement as an example. You would come to the matter private, you'd see the consultant on the day, you'd have your x-rays, you may need to have your pre-op testing. This would be consultation with the anaesthetist, bloods, ECG, inpatient stay, and then of course your post-op care. And this, again, the joint replacement, I'm just going to refer to that because that's the one that I look after the most. The package guideline for that is €12,650. From a reimbursement perspective, because this is what I get asked a lot as well, you are able to claim back 7,000 in sterling for a joint replacement. Okay, so approximately you're looking at about 3.5 sterling you'll be putting towards it yourself. Okay, so it varies between kind of 50 to 80% depending on the procedure. So what we can do is, before you come to Dublin, you can get in touch with me. I'll help you fill in the application form, and then we'll get you your quote. So you can make an informed decision and have your approval before you decide to travel to Dublin. So I always say to patients, get your approval first, see if it's within your means, and they are fully comprehensive packages that we do provide.
Great, thanks, Orla. And then when people are due to pay the matter private for their treatment, what do they need to do?
So we have a couple of methods of payment, and we have got an online portal on the website that you can just click in. It's very simple. Put in the card details. You'll have your medical record number, so this will allocate the payment to your account, and then obviously bank transfer. You can do that as well. We do have a dedicated staff member in our finance team who can do it over the phone as well. So some patients just don't feel that they want to do, especially if it's a large amount of money, they prefer to actually speak to someone and do the payment and have the security to know that it's gone through. So if you're more comfortable, we can arrange for Jeanette in finance to give you a call and go through that information with you.
Perfect. And then once that's done, they get a full receipt, they can submit their claim for reimbursement, and hopefully that is processed reasonably quickly afterwards.
Exactly. So they'll get the receipt from the payment for the hospital. And then if they need any more supporting documentation, some patients come back to me and ask for just a letter to support the receipt. Sometimes they want that. That's fine. I can provide it, and I'll put down what was included in your package with your pre-op consultation, the surgery, and the post-op consultation. So we can give you letters as well from the hospital to support that.
Perfect, Orla, that's great. Thank you. We're still dealing with COVID, but before we get to the COVID questions, what happens if we need follow-up care? I think we've covered that pretty comprehensively from each of our consultants, but just to remind people, if they need follow-up care, what happens?
The follow-up care, your standard is your 6-week post-op. However, we are the only hospital in the South offering this level of cover for 28 days post-op. When we were building the surgical packages, it was really important for us that our patients had this safety net post-operatively. We don't want patients going home, having any kind of query, needing to know, any kind of itch, anything, just let us know. We can look after you, give us a call. So that is fully covered for the post-op care. Like, I do think it's very comprehensive, and like it's very rare that it happens, but it's lovely to know that they can just pick up the phone and be covered. So your post-op care, it's comprehensive and it's covered within the Matter Private.
Great. As I said, we're still in COVID times, although thankfully it seems to be getting a little easier. But in terms of testing and self-isolating, what do people need to do?
So you do not need to self-isolate before the surgery. Our infection control policy is that you have a PCR test within 48 hours of your surgery. So this is covered under your package of care. You don't need to pay for that. You can come and have it done. Some patients come down for their preoperative assessment and their COVID test, say 2 days before, the day before, and do it that way. Other patients prefer to just have the COVID swab locally in Northern Ireland. If they would like to do that, that's no problem at all. They can contact me. I can deduct that off your package price. That's fine, if you're having it done locally. And the result needs to be printed and within 48 hours. So that's the criteria. No problem doing it, but it has to be 48 hours and from an accredited lab and printed.
Great, thanks for that, Orla. Hopefully that's all clear. That covers the most commonly asked questions, but we have lots coming in. If your question hasn't been asked yet, there's still time, so you can submit questions to us at any point during the webinar. But I might kick off by inviting all of our consultants to join us back on screen, and I'll start with some questions that came into us yesterday. Somebody was very organized and sent through a nice long list of questions, so we might just start with those. And they're mainly for Mr. Gwynn, actually. So somebody who is asking about recuperation time following a bilateral knee replacement, what would they typically expect?
With regards to bilateral knee replacement, I would expect in general that if I was to say that I'd expect most people to be gone home at, say, 2 to 3 days, it's often an extra day in hospital, just with the amount of work they have to do with regards to their physiotherapy. But and I see a further question down relating to the same. You wouldn't be leaving the hospital till you were fully mobilizing, doing steps, whether that's with 1 or 2 knees. There's no time period where you're immobile. It's just really a function of one. You'd have to, before the operation, realize it is a bit more difficult at the start and it takes more work from the patient. And then it's a function also of our pain management to make sure that you're adequately controlled so you can do all your physiotherapy and get the best out of both knee replacements.
Right.
As regards overall recuperation time, if somebody for 1 knee replacement set was doing quite well, maybe at 6 weeks, for 2, I would kind of say it might be 8 weeks before you're at that same point on some occasions. But obviously then you already do have both done at that stage. So it's often a particular subsection of people who are keen on bilateral knee replacements are those who are still working and are maybe they're self-employed and don't want to take off two separate large portions of time for recuperation. Overall, the summation of the bilateral procedure would lead to less time off than two separate ones, and it's often one of the reasons that people might go towards a bilateral knee replacement.
Okay. The same person had a question about us having had a steel plate in their ankle several years ago, and does that have any impact on their eligibility to have knee replacement on the same leg?
No. As I say, a steel plate up near the knee might just change a little bit how we would do the operation and what kind of equipment, but something that far down the ankle wouldn't tend to be a problem at all.
Okay.
I say, but having said that, it might involve just one extra X-ray to make sure. Sometimes when people have had an injury and a plate put on their leg, there can be some alignment issues that you should be aware of before you go ahead and do a knee replacement. But that's just a technical aspect from my point of view.
Great. Okay. And the last question from that person was just asking about the discharge and how long they need to stay in Dublin, which I think you covered. It's typically a couple of days after surgery and once they're mobile again.
And again, I'd expect to you're leaving the hospital when you're comfortable, be mobilizing with a frame or generally crutches, and 3, managing. If you're at home and you have stairs, you need to be able to manage the stairs before you go home.
Yeah.
And then as regards the actual travel, again, I wouldn't see any problem about heading straight back north afterwards.
Right. Okay, super. Thank you for that. That was a great series of questions from somebody who was super organized yesterday. One of the first questions that came in, actually, Mr. Poynton has very kindly already typed an answer to it, but I'll ask it for the benefit of the entire audience. It was a question about what to bring for the first consultation. Does the patient need to get their diagnostic images and notes from their consultant in Northern Ireland for the matter private, or are they already available digitally? So, Mr. Poynton, I think you had a view on spine patients, what they need to bring with them.
Yeah, ideally we need diagnostic imaging. So if you've had a scan, most people will have had an MRI scan, unless they're not able to have an MRI scan, then it'll be a CT scan. So we'd need that, and ideally that should be done within 6 months of the surgery, and even better if it's sooner than that. If it's beyond 6 months, we'll want to repeat it. And then to help us, if you have any information from your consultant visit, so that would be ideally the letter from the consultant back to the GP outlining what you're listed for surgically, so that we know what it is, and also any treatment that you've had, such as injections or pain management intervention. It's good to have that, but very basic would be up-to-date MRI scan and a letter from your consultant to the GP.
Great. Okay. And for the other consultants in the group, anything different for your specialties, or would it be pretty consistent? Mr. O'Malley or Mr. Quinn?
So I was answering a query on
Thanks.
Sorry.
So in terms of what people need to bring with them for their consultation, MRI?
Oh, well, it's sort of a set piece at this stage. So their MRI imaging has to be here, plus the official report, the biopsy reports, and all the correspondence on the case. So the cases don't come down without us seeing the package of information first. So if there's some gaps in that package, we can ask for it in advance so that we don't have that disappointment of missing a critical piece of information. Okay. So in terms of imaging, prostate cancer imaging, I would have a sort of a rule of thumb that the imaging has to be within 6 months. Otherwise, we'll repeat it again, but that doesn't delay anything because we can usually twin that with their pre-assessment clinic visit and bundle as much stuff into that one visit and make it as seamless as possible. So there'll be one visit down, the chat, the consultation with the nurses, consultation with the anesthesia people, anything else that needs to be done, and then they return on the day of the procedure.
Great. Okay. Mr. Quinn and Mr. Burke, anything to add to that?
If I could just add there, yeah, I mean, in general, we can take referrals, with the GP letter. We often get those referrals, but it's really important if you can bring your recent optometrist information. So information about your past ophthalmic history and your glasses. And again, as with the others, kind of a letter or whatever was sent to your GP and or your optometrist following the listing visit in the NHS. That would be really great.
Great. Okay.
And for myself, as I say, you really just, again, like Thomas said there, the listing visit letter will be present on the day. And with regards to hip and knee replacement, we get a new X-ray that day just to go through with you again, and basically to say, has anything changed? Has the disease process gotten worse, that we changed the plan, exactly what we're going to do? But I say that can all be taken care of on the day with your pre-assessment.
Right. Okay. Thank you for that. Orla, one for you. Somebody is a little bit concerned about their letter and perhaps maybe lacking in some detail. They've been told their consultant has just written painful left hip as their primary diagnosis. They have hip dysplasia and arthritis, but they're concerned they might be refused something on the scheme because the notes aren't as clear perhaps as they could be. What's your view on that?
Yeah, the criteria is that you are for a listed procedure with the HSE&I, so they will look, that's obviously the clinical issue that's going on with the osteoarthritis and that, but they will look to say care plan is for joint replacement or whatever the plan is. What the patient could do is contact the consultant secretary and maybe ask for the letter to be amended, and then that could work for their support to the board. I'm sure they probably are on the list, but they just haven't spelled it out. So the best thing to do is to get the consultant to just do an amendment on the letter. I have to say the consultants in Northern Ireland have been brilliant. They really support their patients in this scheme. Same as our consultants would if one of their patients was looking to seek treatment, you know, they just want their patients to get the care that they need. So I'm sure that would be no issue if they reach out to the consultant secretary to get that.
Great. Okay. And while you're there, another question, which is, I think we've kind of answered already, but what is the likelihood of the scheme being extended beyond the 30th of June? Have we any insights about that?
We don't at the moment, and that's why we're trying our best to just support patients with their application as best we can. With things like say spinal surgery, what we actually do offer is patients that need to have complex fusions. They aren't as straightforward as just a hip or a knee. So what I will offer to do is take maybe their most recent clinic letter. And for example, I might send it to Mr. Poynton's team. Marie, who is his operations manager, might run it by Mr. Poynton to get the codes. So therefore, we can go back to the patient with a really good idea on pricing. They can make their application, and then when they come down, they have all that in hand. So we're trying our best to work with the process to get them in, to show the consultants the letters, to get them coded. So we're doing everything we can to meet the deadline for the patients to get it through. So you have loads of time to work with. You have got 9 months, so it's just meet your deadline as best you can, because we don't have any oversight, unfortunately.
Yeah. And another question is related to that, actually. When we said earlier there's a 6 to 9 week wait following the application, is that when you apply for the approval or when you're fully approved in matter private? I think it's really, that's the typical time it's taking with the HSE&I at the moment, isn't it, to be approved?
So we advise patients to get their approval, which takes 6 to 9 weeks, and then you have no waiting list really in the matter private. So that's why we say get your approval, and then when you come down and the surgeon has you in clinic, they know you're approved. We can make your appropriate care plan. So we would encourage you to have your approval, and then it's kind of, as I said, a week or two to clinic. So it's not a 6 to 9 week wait for the matter private. It's for the approval from the HSE&I.
Yeah. Mr. Quinn, I think you've already answered this question about getting both knees done at the same time.
Yeah.
Not an issue for most people, is it?
I do think it's on a case by case basis, in that it really does depend on the patient, and you know, I'll always tell people with regards to a knee replacement, it is hard work, and getting yourself bilateral knee replacements, there's definitely good reasons to do it, but it's doubly hard work. And before I would suggest someone would have it done, you need to be sure that you'd be able to handle that volume of rehab. If you think about it, if you're doing a couple of hours of physio a day, all of a sudden it's 4 hours of physio a day because you have to get that other knee afterwards. So you want the best result for both knees. And if someone felt that maybe it was a bit too much, there's good reason to stagger them. So I've done it quite regularly, but I would, on a case by case basis, just go through it with someone, and the reality of having a bilateral procedure, which is time saving and has really good reasons to do it, but it's hard work on the patient, and I want to understand that before we do it, you know?
Yeah. Yeah. Another person's asking a similar question on behalf of their mom who's 78
Yeah.
and until she wants a double knee replacement. So
Yeah.
is that going to be too much of a burden on somebody maybe a little
I
older?
think I think it's definitely a discussion. And as I say, as regards age, as you say, physiologically, people can be very different. And as you say, if somebody's really gung-ho and wants to do it this way, it's something I would definitely consider, but it would be something that we'd have a good long discussion about at our consultation. And as you say, there's pros and cons to doing them together or waiting as little as 6 to 8 weeks and doing a second one.
Okay.
And as you say, but it's definitely open for discussion for everybody. And then it's just what we think is best at the end of that discussion, really.
Okay. And Orla, just in terms of making payment, to clarify, if somebody's had their initial consultation and they change their minds and doesn't want to proceed, what way does that work?
Yeah, so if they come to Dublin, we had a patient recently who came down, had their consultation, and then they actually got called on the urgent list to Musgrave. So it's the first time I've seen it happen, but they did get called for their procedure in Northern Ireland. The approval from the HSCNI is broken down into consultation, surgery, and post-op consultation. So you will be able to claim back the consultation from the HSCNI. So you pay it to the Mater Private, and then you'll be able to be reimbursed for the money. Even if you decide that you're going to go ahead with your surgery elsewhere in Northern Ireland, that's fine. They can still claim it back.
Great. Okay. So the out-of-pocket expense is reduced once they get the claim back. Pain management for somebody who's having a total knee replacement. Mr. Quinn, there's lots of orthopedic questions coming in. So sorry, you're on the spot again.
No, yeah, I know. And really, it's really a cornerstone of knee replacement is pain management. And I explain this a lot to the patients that I do both hip and knee, but knee replacement is just a tougher procedure for the patient, especially in that early phase. So pain control is really important. And we kind of tackle it in a 3-mode manner. At the time of surgery, we give a periarticular injection around the joint of morphine and local anesthetic and a couple of other compounds to make that first day and first night post-operative quite comfortable so we can get the knee moving, get it bending. Then beyond that, I would rely quite heavily on opiate medication for the first couple of weeks, and I would encourage patients to take it. I know people can be very cautious about it, but my feeling on it is that those people who don't need painkillers aren't doing their physio. And I really kind of encourage people to use their analgesia so they can get that best result, because it's all about the first few weeks as regards what kind of movement we can get back in the knee. And coinciding with that, actually the cryotherapy, or it's an ice cuff that we put on the knee, is excellent with regards to helping swelling and pain, especially around the time of your physiotherapy. I would tend to recommend somebody doing their physiotherapy 3 times a day that they take their painkiller half an hour before, they ice it for half an hour, then we go through the program of exercises they have to do, and then they re-ice it for half an hour, getting ready for their next session in about 3 or 4 hours. And I think that combined approach really gives them the best chance to get the most out of that knee replacement.
Perfect. Okay. There's another question here, which is about transport, and probably, although it's addressed for you, it probably applies to some of the other procedures too. And if the car journey isn't really an option for various reasons, are they okay to go home by train?
I seen that, and I said, anything is possible, but probably not advisable. As regards just the simple logistics, somebody going home on a train after a knee replacement, you'll have a bag. There's steps, you have your crutches. I think if at all possible, if a lift could be arranged, I think it's the one time where I would maybe try and put a little bit of pressure on friends or family. I think it is a lot, I think somebody that motivated obviously could be looking at heading home day 2 after their operation. But I think a travel through Dublin on a train with a bag, with crutches, I think you're asking for a fall or some unpleasant event that just slows up your rehabilitation. So I would be apprehensive about somebody heading home by themselves such a distance.
Okay, and Mr. Poynton, would be the same for any of your patients? Is train journey an option?
Yeah, some of my patients will travel by train, and it can be a little bit easier than after a knee replacement. I think certainly after a knee replacement, you'd be looking for trouble, really. I agree with Mark. I think after the bigger spine surgeries like spinal fusion, it's not really advisable.
Okay.
And again, if your train is delayed or you miss the train or there's any issue, then you're hanging around hoping that your pain will be all right. You're better off getting somebody to take you.
Okay.
Just to actually, while I'm on the speaker, there's been a few questions coming through about medical comorbidities and internal cardiac defibrillators and things like that. So best thing is make sure you have a list of all your pre-existing medical conditions, all your medications. It's really crucial that we know that if you're on an anticoagulant or anything like that. Now, most of that will be picked up at the preoperative assessment, but sometimes your pre-op assessment will be the week before surgery or even the week of surgery. So if you're on an anticoagulant, your surgery will be cancelled because we can't do it, because some of them you'll have to be off for a week, particularly for spine surgery. But you know, all the medical comorbidities we can cater for in the Mater Private, but you have to, if you're high risk from a medical point of view, you're better off staying at home in somewhere that is close to where you live, where you've got all the supports. I think coming to Dublin, if you've got serious medical problems, you're better off, I think, not doing that, would be my view.
Okay. Thank you for that. That's great help. I think this is a general question, and perhaps Orla might be able to best answer it. Is there any flexibility on the procedure date, Orla?
Yes, of course. Once you come down for your initial consultation, we do obviously have quick timelines to surgery, but it's coming into summer months, so some patients do come down and there's holidays and weddings and loads of things going on, so we can obviously push out the date to suit the patient. It is helpful to let your consultant know if you do need to have a pre-op assessment. They're valid for 30 days, so we will be ensuring that that's lined up to your planned surgery date. We don't want to go and get you worked up for surgery and then your surgery date goes far out. So just mention that in your consultation if you'd like to push the date out a little bit. Okay. That's no problem. But
as you said, summer, even though there's lots going on, summer can be a good time to actually have a procedure done, because there may be less urgent care going on. There's maybe more possible to schedule elective surgery like this during the summer months. So
we've excellent capacity.
July and August can be a good time to get something done.
Yeah, certainly for the coming months now during summer. Really good timelines.
And again, Orla, while I have you on screen there, can you apply for the reimbursement or for the procedure prior to being approved or going on the waiting list in Northern Ireland? I think you've answered that already, but just clarify.
Yeah, so you can apply for the approval once you're on the waiting list. So just to make sure that you're on the list, and then you can make your application and then come down to ourselves. So that will be the running process to ensure you're on the HSCNI list, have proof of that, and then make your application and come down.
Yeah, so you really do need to be on a list in order to have approval for reimbursement. And then a pricing question, Orla. I know you can't give exact prices because it's all very individualized, but a typical price for cataract surgery, can you give us a ballpark figure for that?
We have a package price. So cataract surgery, so per eye, it's common that patients have bilateral cataracts, so it will be carried out in 2 procedures. So the package of care covers the consultation, the biometry, the preoperative assessment, so that would be the ECG or any testing that you might need. The surgery and the post-operative care is €2,700.
Okay, great. Back to you, Mr. Quinn. There's a question about knee replacements, and are they done under general anaesthesia?
Typically, both hip and knee replacements are done under spinal anaesthesia, as it's seen to be the safest for the patient. And often people are very apprehensive about this portion of the surgery, and they're concerned about what they're going to hear or see, and which is totally understandable. Now, when we say not general anesthesia, we can sedate somebody, and all general anesthesia means is that the machine is actually doing your breathing for you. So we would often numb people from the waist down and give them some sedation if they just wanted to sleep during the procedure, but they're still breathing on their own, and it works best as regards recovering for their lungs, etc. A very small group of people would get a general anesthetic, and that's just related to if they'd have maybe previous conditions with their spine or etc. But as I say, the majority, at least 95% will be done under spinal anesthetic. and it's done all the time, and it definitely seems to be the best for the patient, you know.
Okay. Thank you for that. I can see we're already going over time, but we have some more questions coming in. We maybe just take one or two more, and then if there's any we can't get to, we'll answer them offline. Mr. Poynton, you did mention comorbidities, and here we have a question for somebody whose father has had a recently failed hip replacement and also has Parkinson's. Is there anything can be done for vulnerable patients to mitigate and the increased recuperation time? Is that something we can answer now, or is it more of a, you need more detail about that?
Yeah, I think it's back to my comment on if a patient does have a lot of extra needs and are high risk, this may not be the scheme for them, because if there is an issue, a patient can spend a particularly long period of time in hospital, and certainly from my perspective, if there is a very complex medical situation, I can't discharge the patient, and in current times there may be issues having visitors and so on. So somebody doesn't necessarily want to be away from home for a long period of time.
Yeah.
So I think it's better to avoid coming if there's lots of issues. But you know, there are certain conditions that we will manage very proactively to get patients mobile, to have extra level of physio, extra medical backup. There's questions about diabetes and so on. So, you know, sugar control is very important in the perioperative period in all surgeries. It increases your infection rate if it's not. So we're very mindful of that. So that, you know, most of these things we can manage.
Yeah.
Okay.
And there's a question there just come in about scoliosis. Can they have an epidural if they have scoliosis?
No.
Okay.
Quick answer.
Very clear answer. Thank you very much. I think that covers most, if not all, of the questions that we have had from the audience this evening. I'll just have a quick look and make sure we haven't missed something. But if we have missed it, by all means, email Orla or contact her by telephone, or if we catch it, we will drop you a note afterwards. But I think that covers everything. Just before we go, I just like to remind everybody that if you do have more questions or you need more information about the scheme, how to apply, what you need from us, contact Orla. She's there Monday to Friday, and you have her phone number on screen. You can also go to our website. There's lots of information on the website. There are some videos that you may find helpful if you are interested in cardiology surgery or other types of surgery as well, from a previous meeting we did back in April. So lots of information you can access there on the website. If you have any more questions for us, you know, just pick up the phone. It's as easy as that, and we'll do our very best to help you over the next number of weeks and months. I'd like to thank all of our speakers tonight for joining us. I think you've really provided a very comprehensive and reassuring set of information for patients who are interested in the scheme. So thank you for doing that. And just to remind everybody, if you wouldn't mind taking 1 or 2 minutes at the end of the meeting just to share your feedback to it in a survey that will follow. That will just give us a sense of whether we've met your needs tonight or whether there's different information we need to provide. So we would appreciate your feedback. Thank you very much to all of our speakers and to everybody who's joined us online tonight. We had a huge audience, and it shows there's huge interest in the scheme and being treated as quickly as possible. So we appreciate you giving us your time tonight. Thank you for that. And on behalf of everybody at Matter Private, stay safe and good evening. Bye-bye.